for that, and so that's a somatic dysfunction. And then some people are like, well, I'm a classical osteopathic physician, so I only treat osteopathic lesions, but the soma is a kind of a nice term, and that was kind of the direction they went, and so that's kind of our definition. So, and then to find somatic dysfunction, we have to identify it manually, and we use this TARD framework. So we look for tissue texture abnormalities. So you're running your hands along, you feel some changes in the tension of the structure, or maybe you notice some changes in the temperature, and you start reasoning in terms of its physiologic function of that tissue that's under your hands is starting to be altered based on the tissue not feeling like everything else. That would be tissue texture abnormality. You may notice asymmetry of the structures that sometimes for some people jumps out. Restriction of motion. Many physicians they find an area that seems to have less total motion in general, and then they start looking at its specific directions of motion that it's restricted in. And then oftentimes, in order to build rapport with the patient, they find these areas of dysfunction, they push on it and say, is it pretty tender here? And they may get some confirmation there. So any of these being present is kind of our physical exam manifestation of saying, we did a physical exam, somatic dysfunction is present because I found one or more of these elements, right? So then in terms of our indication for doing OMT, somatic dysfunction. So if you diagnose somatic dysfunction based off of any of those TARD findings, then you now have the indication for doing OMT. And then sometimes people will do something that they call empiric treatment, where they think, well, you know, this person is having a lot of trouble just maintaining their homeostasis. Maybe they're in the hospital with pneumonia, and you go in to see them, and even before you see them, you think they're probably going to be somatic dysfunction. I'm going to go ahead and treat them. So enhancing homeostatic mechanisms can be important, and then this musculoskeletal or the somatic framework is a major portion of maintaining our homeostasis. General considerations for doing OMT. You know, as you're doing your OMT, it's not like your hands were awake for diagnosis and now you're doing a technique, so your hands are just all about the technique. You're still monitoring the tissues and that somatic dysfunction as you're doing the technique. And so as you're monitoring the response, then one technique may lead you into another technique, which is part of what makes it into a treatment, is that your decision on what you're doing next is based on how it's responding. So it's not like you pick the chart up off the door and you say, oh, this is Mrs. Jones, she's here for neck pain, so I'm going to go in, I'm going to do HPLA to her C3, then I'm going to do soft tissue to her thoracic spine, and then I'm going to counterstrain this anterior tender point on the front of her neck, and then I'm going to leave. No, you go in, you do your evaluation, and you start seeing how things are responding as you go, and that's typically how a technique is done. And so to get our students from that first viewpoint onto the second point, you know, it takes several years of training, and they pick it up in the clinics as they're expanding their skills. One technique may treat more than one type of dysfunction. Sometimes you're in there and you're treating something and you did your evaluation and you have 4 or 5 things that came to your attention and you're like, but this thing at T4 is the worst thing, so I think I'm going to start with that. And you treat that, and then all of a sudden 3 other things that you thought you might have to address are now gone. So that would be one technique, treating multiple dysfunctions. Maybe you hit something that was a significant or key type lesion. Sometimes you go in and you treat that thing at T4 and it just laughs at you. And it says, I've had 5 people do that to me and that didn't do anything. And so then you may have to figure out what it'll respond to. So you may need to do more than one technique as you're trying to figure out what's going on. Hopefully, as you get along in years, that you may use many different types of techniques as you do an OMT. In fact, you might go in and you might do something that if someone was watching, they said, oh, that looked like counterstrain, that looked like soft tissue, that looked like myofascial release, that looked like HPLA, I don't know what that looked like. And then maybe you would get to the point where you're just interacting with the tissues under your hands and you get out of the room and now you're trying to figure out, well, I got to document this. What techniques did I do? I'm not really sure what to call them, but I'll give them names, right? So that's the goal. right? You might start out being very technique-oriented, very specific, and then by the time you've been at it a while, your hands are to the point where you're just trying to figure out what this tissue needs, and then you're just having to create a note to figure out what are we going to call what I just did. That would be a nice place to be, right? Dosing, so limited by the patient's ability to respond. So Mrs. Jones, I see her chart, I'm like, I'm going to treat her neck and her thoracic spine, her lumbar spine, I'm going to treat this, and this, and this. And then I go in and get started, and you know, she happens to have a cold, she has these other things going on, and we're just happy that we're able to treat 2 things on her today, because anything more might be a little bit more than she could handle, right? So, and then you may have someone that comes in that's pretty healthy, and you treat the things that you thought they needed, and they're like, well, I got this other thing. And then you get your hand to the doorknob, and they're like, well, I got this other thing, right? So then some people can take a lot more, right? And so just figuring out how much they can manage is important, and then giving them time to go back and make the changes and adjust to it. And so it's, you know, there's not a lot written on what is the optimum duration of time between treatments. There's not a lot of good studies on that, but those are things that we think about. Dr. Still said, let's just find it, fix it, and leave it alone. I got books to write, I got a school to start, I got a profession to create. Allow the patient time to respond. And then different patients are going to have different abilities to respond. Some people may need smaller treatments more frequently. They may need more time in between. Some just general guidelines.